So today I will be speaking on family-centered care, and some of the learning objectives will be defining family-centered care and really defining family-centered care, how it relates to the Maternal and Child Health Bureau, which is where I work through the state government, which is pretty much the focus of the family-centered care definition that we focus on here. But we'll also help you understand, using the principles of family-centered care while working with families, understanding how the role of cultural competency is, can be guided in your family-centered care with families, and also understand how to utilize medical home model as a way to promote family-centered care through care coordination within that medical home model. So in defining family and family strengths, the Beach Center on Disability defines families as a family includes the people who think of themselves as a part of a family, whether related by blood or marriage or not, and who support and care for each other on a regular basis. So as we all know, families can look very different from one another. For example, my immediate family is very small. I am a single only parent, and it's just me and my daughter Lily. I do have a 29-year-old son who is out on his own and lives about an hour and a half away, but in my home, it is just me and my daughter Lily. So we know that families do not have to be blood. Everyone defines their family in their own unique way. And with that in mind, we also know that families all have very unique strengths in addition to other qualities. But today we're thinking about families and family strengths. I was wondering if maybe some of you raise your hand, and then Michael will unmute you as we go through this. We're going to try to have a lot of discussion around this. If you could come up with a few words that could identify key strengths within your own family or your external family. I'm trying to think of a couple of strengths of my own family while you guys feel free to brag here. These are your bragging rights right now. And a strength of me and my family is very resilient. So I have we are very resilient. Lily and I have been through so many things together, from receiving a prenatal diagnosis of Down syndrome and her developing high drops and almost passing before I even had her, to many struggles, from financial struggles because I wasn't able to work, almost losing everything because I was at the hospital and at that time not able to hold a job, through many surgeries that Lily's been through, and moves for my job. And we always come back stronger together. And so I think resilience is a great family strength that I feel with a lot of families. Does anybody have any family strengths that they would like to identify within their own family?
We do have a couple suggestions coming in. Michael Palmer says, I would say my family is supportive and understanding. Sharon Milberger says open communication.
Those are great ones. So if we're thinking about some of the strengths that Sharon identified, and I'm sorry, Mike, who was the other gentleman?
Michael, and Jane Turner says we enjoy being together. Oh, and I have one from Molly. Molly, go ahead.
My family is very reliable and supportive.
Those are really important strengths to have too. And these are all great strengths that all of you are coming up with. I really appreciate your input on this. Is there anyone else? So if we think about some of these strengths that everyone has just brought up, can you think about how you can use those strengths as a way to help you provide care for these families, or maybe an example of how you can use these strengths to really benefit these families or promote that family-centered care piece?
All right. I was going to say, for the families that enjoy spending time together, you can help to sort of model or create therapy plans that would include your family to help to achieve better outcomes, but kind of involve the family in the treatment plan.
Absolutely. That was an excellent example of how you can use those family strengths to really empower the family. And like you said, they like to be together. So Let's work on things that can bring them together where they feel like they are, spending time together as a family, maybe, out at a park, whatever it may be. But I love that. That was an excellent example. When thinking about the different strengths for families that you've come up with or within your own family, how could you use that strength as a way to provide better care for families or family-centered care, or think of those family strengths in developing a care plan or something else, therapy to work with the child when you're not there. So that's okay. We can move on. I appreciate everyone that did offer some input, and it's just sometimes just a good way to think about outside of the box and how you can use the things that we don't normally think about as a way to improve care for families. So the Maternal and Child Health Bureau provided leadership in the development of the family-centered care concept way back in, I believe, '87, when U.S. Surgeon General C. Everett Koop made a call to action for a system of care that was coordinated, family-centered, community-based care for children with special health care needs and their families. This concept was mandated in Title V of the Social Security Act. And then again in 2004, the National Family Voices Organization held a meeting bringing together families, providers, researchers, policymakers. They wanted to bring everyone together so they could really hone in on the concept of family-centered care and what does that mean and how can we utilize a family-centered care model in order to improve the care of these children with special health care needs and their families. And so that's why they brought all interested stakeholders together, and so they came up with a mutually agreed upon definition. And according to the Maternal and Child Health Bureau, the definition that came out of that meeting is that family-centered care assures the health and well-being of children and their families through a respectful family professional partnership. It honors the strengths, cultures, traditions, and expertise that everyone brings to this relationship. Family-centered care is a standard of practice which results in high-quality services. So when we think of family-centered care, we can really imagine creating a building from the ground up. And so, if you're building a building from the ground up, one of the most important parts is to make sure that you really have a solid foundation on the ground before you start adding those bricks and building upward. And so we kind of think of family-centered care in that building concept where the foundation is the partnership between the families and the professionals. And that's one of the reasons it's really important to make sure that you work on building a solid partnership with the families that you work with along the way. I do a lot of trainings for families and for professionals, but in the trainings that I do for families, we really talk a lot about building the family professional partnerships. And what does that mean? We think about partnerships. We partner with people, in many areas, pretty much every area of our life we have to build relationships. So when we're thinking of this family-centered care concept and thinking of the foundation being a partnership, it's really a relationship. And in order for anybody to have a relationship with somebody else, we have to have certain things. And, we have to have, probably some ground rules between each other, or some commonalities and some mutual understanding if we're going to build a good relationship, right? So when we're thinking of family-centered care in a more of a relationship building aspect, you can think of the building blocks, being the core principles of the family-centered care. So, and we can open this up for a good discussion if anyone would like to. Do you need when you're building a partnership with someone? Would anyone like to chime in? What are some of the things that, so I would guess for me, one of the things I would really have to have to build an honest partnership with someone is I'm going to have to be able to have trust. I'm going to have to trust that person in order to build a strong partnership. And can anyone think of something else?
I would say not necessarily the same goals, but definitely a mutual understanding of the goals of both parties.
Right, absolutely. And so, and this instance, in the, thinking the partnership between the provider and a family, the mutual interest would be of that child that's in the center, right? And so we come together to work in the best interest of that, not only the child, but the whole family, and how we can make the outcomes for the child the best, at the same time help the family become stronger, right? Because many times you would like to also, have to have that respect. I don't think anyone can have a good relationship with anyone without mutual respect. And this is one of the things that I do share with families all the time, is because, many times we have parents go in there, but my instinct is telling me this, and I want you to listen to me, and this is my child. And yes, we want to acknowledge that parents are there 24/7. Parents know their child best. They are with their child all the time. Professionals come in and out, therapists, teachers. We have a lot of people in and out of our child's lives, but the parents really know their child best, and we want professionals to hear that. We want professionals to know that our child is more than just their disability. We want the professionals to know that, what our child likes to do. For my daughter, Lily, she's 12, and she still loves baby dolls. Now, I love baby dolls till I was like 10, so we can't just blame it on Down syndrome, but, she loves baby dolls, and that's one of the things she loves. She's very motherly, and she loves to care for people, and that's important to note. And many people, of the professionals that work with her, because, for instance, in a school issue, she was really butting heads with this other girl, and what turned out is this girl really wanted to mother Lily and take care of Lily, but Lily doesn't want to be mothered. She wants to take care of other people, and both these girls had this same goal in mind, but neither one of them wanted to be taken care of. So when I also speak with families, though, to let them know, they do trust the expertise and the education that the professionals bring. I share with families, people didn't go to all that school just so they could come here and give you inaccurate information. Professionals, they went through a lot of school because they care about children, because they wanted to work for children, and they wanted to make a difference in the lives of families. So, you have to have that mutual trust on both ends and be open to communicating and sharing that information. Is there anything else that any of you can think of in order to build a relationship that you need?
Yeah, going off of that, I think something that's invaluable is the healthcare provider and the family really working together. And I think as healthcare providers, our goal is to, discuss with the family all the options and then value their opinion in which option they think they'd like to go with and which option they would like, think would work best for their child and with their own personal goals for their child. So I think really valuing what the family, what their goals and objectives are, I think makes a big difference and really builds upon that trust.
Absolutely. And I think that goes a long way to building that strong partnership where you know that if the family's struggling, they're going to be more open to maybe sharing some information with you that maybe with another provider they wouldn't feel as comfortable sharing, because they know that your value, you understand their values, and you also consider those and understand what those values mean to that family. Okay, so now we're going to talk about family-centered care within a medical home. And so one of the things I would like to ask all of you, when you go to a provider, what are some of the things that you would hope your provider would offer? What are some of the things that you would like to see from your doctor's office? Okay, so I'll give you a good example. I pretty much work 9 to 5. That's pretty. Some weekends, some nights here. I'm here until after 7 tonight, but majority of the time I'm Monday through Friday, 9 to 5. And so it's very helpful for me, for my daughter's providers, to possibly offer times when I'm not at 9 to 5. Now, especially a lot of the, children's hospitals and et cetera, where we go to do not offer after-hour appointments, but that is one feature that I would be really excited about, Saturday appointments or other appointments outside of that normal 9 to 5. That's kind of where I'm going. Does anybody else have anything they could think of? All right, well, you can write this down and maybe a good discussion at our face-to-face or at another time. But so I just, within this medical home concept, it was actually first introduced back the American Academy of Pediatrics in 1967. And, really in the beginning, this was really a way as to define a place that would be the center of the child's record. It really, the point was to have one centralized local record that would have all the information that your provider would need to see, especially in regards to the care of children with special health care needs. And since then, it's, evolved, and we have not only the patient-centered medical home, family-centered medical home, but in the beginning, it was really to provide that one place where they could have the child's record, that everything could be held together, all about the child, so it wasn't in pieces everywhere. And I assume all of you know what a medical home is. Can all of you raise your hands if you do know what a medical home is? I guess I won't be able to see if you raise your hand or not, but...
Yep, several people are.
Okay, great. So I won't go into all the details. I don't know, like I said, I assume that this is taught somewhere in within your clinical training, but maybe not at the college. I don't know. But the Family Centered Medical Home is in a building. We do this training for families discussing medical home and educating families about medical home, because most families have never heard of a medical home. When we do a training on care coordination and we look at families and we ask them, does anyone know what a medical home is? It's like the deer caught in the headlight. They have no clue what we're talking about. But everyone knows that they want one. They're like, whatever it is, it sounds great. Can you sign us up? But it really isn't. It's not a building. It's not a home or anything like that. But really, it's a model of healthcare delivery. And like I previously stated, it was the American Academy of Pediatrics defined the medical home in a policy statement back in 1992. And since then, it's really been developed further and as a way to deliver that primary care that has a variety of characteristics that will ultimately help contain cost and result in improved health care outcomes for children with special health care needs and a variety of other things. Excuse me just one moment. I'm trying to get this other computer out of here. Here we go.
Hi, Lisa. Alyssa says that she is not trained on that model. So.
Oh, great. Okay, so in the brief definition that I gave you, did that help enlighten you? I mean, we're going to go into more, but do you have more questions? I didn't want to go into too much detail, although we will go into more detail right now. So I just want to make sure, did that make sense to you, what I said so far, what was shared on the screen? These right here are the characteristics of a medical home. Now, many medical homes are actually, so for in the state of Michigan, it's a way to deliver this primary care. And for instance, my daughter's pediatrician, Dr. Jane Turner, who is also on the MyLen team, their pediatric practice is considered a medical home. And part of, and maybe Jane can chime in here from the provider side and give a little more insight into that. But they have to be able to show certain data and show that they're able to meet the criteria for a medical home in order to be, Jane, is it an accreditation or it's a certification?
You can go either way. There is a standard way as to the NCQA, which is an accreditation, or the certification through Blue Cross Blue Shield has a medical home certification process where the practice has to show that they meet certain criteria, one of which is what you just mentioned a couple of minutes ago of having some evenings and or weekend hours, having some accessibility openings for individuals and families after 5 p.m. or on the weekends, having someone available round the clock to answer questions, and that person needs to have access to the medical records, so that can't be just someone, a healthcare professional who just wings it, but someone who can look up your child's record. The medical home needs to be responsive to the needs, so that if an individual needs more time, you can give them more time. They need to have the information in front of them when they see the child or family. So again, they're not flying by the seat of their pants. So for instance, one of the things that has happened to our practice over the last 10, 12 years as we became more of a medical home is we track our referrals and make sure we get the consult reports back. And if any of our children in our practice are seen in the emergency room or hospitalized when they come into clinic to see us, we have that record before we go in to see the child. The old standard was you go in and you see the child and then you pop your head out and say, hey, can you call the ER and get that report faxed to me? And then you might get the report before the end of the day, but long after the patient goes home. A big part of the medical home is to be family-centered, to really build your practice around the needs of the pediatrics of the children and the families, rather than driven by the convenience of the providers. It's a hard one to get to because we all like to run our businesses in ways that suit us, but a big part of it is to think again and make sure that it is indeed meeting the needs and organized to meet the needs of the families that you serve. The other is that it's comprehensive, that you meet all the needs. In primary care, you might need to refer to subspecialists, but the idea is you're there for acute care, for preventive care, and to manage chronic health conditions. So I'll stop there and take questions or comments.
Great. Thank you so much, Jane, for stepping in and explaining it from your perspective and what actually happened. Okay, great. So one way to receive, we do a lot of talking about the importance of care coordination for children with special health care needs and their families. I think at the last face-to-face, we discussed that, families have many providers in their child's life, and so for instance, for my daughter Lily, she has providers at U of M. I think she has 3 or 4 specialists. She sees an orthopedic doctor, she sees ENT, she sees audiology, she also sees cardiology out at U of M, and then we also have a pediatric ophthalmologist out at Children's Hospital Michigan. And then we also now have a pulmonologist within the Lansing area, and our pediatric provider is here in Lansing. So she has a lot of different providers, and it's that care coordination piece is really important for families, and it's also a big piece of the medical home as well. So for instance, one of the things when I first moved to Lansing and took this job and was connected with Dr. Turner's pediatric practice, my daughter was born and developed hydrops, which is fluid in the lungs. Her lungs are collapsed, and she was born in respiratory distress on a vent for about 10 days in the NICU for over 6 weeks, but she had always had respiratory issues. One of the things that nobody had ever given to me, and actually prior to moving to Lansing when Lily was 5, she had been hospitalized a lot for bronchiolitis, respiratory infections. Anytime she got sick, it went straight to her lungs. But nobody had ever given me an asthma action plan. No one ever discussed an asthma action plan. No one ever discussed with me that when I started hearing that cough, I could start using that rescue med. And so that was one of the things that I was given at Dr. Turner's office. And I can assure you, I'm sure that some of it is her immunity is getting better. But she has not been hospitalized for any respiratory issues, not once, since we've moved here 7 years ago. And another thing that they gave me, that they have what is a care coordinator within her practice that really comes in and discusses, other issues we may be having, whether it is, related to Lily's, behavioral issues in school or nutritional issues, and trying to help get her weight down and healthy eating habits, etc. But we really have a full team within that practice that helps to receive, to provide this care coordination for us, helps to get us referrals when we need to make appointments with new doctors. And it's just, really has been a blessing for us being up here, and the, the quality of Lily's health is done, even though she still has moderate to severe asthma and getting ready to go see pulmonology. I mean, really just knowing that I could start asthma meds ahead of time. Nobody ever shared that with me. I did not know that, and I think sometimes maybe providers assumed I knew that, and it was just nothing I'd ever known. So one of the other things is if, when we talk about accessibility, and so maybe their office doesn't offer Saturday morning appointments, but I know if I'm having an issue with Lily and I call and I leave a message on the nurse's line, they generally call me back within an hour. I tell families this all the time and they're shocked. And I'm like, I can call those nurses, they know Lily very well, they call me back, and whatever the issue is, maybe Lily has an ear infection, and so maybe instead of having to bring her in every time, maybe I get refills on her eardrop medicine. So that helps me from having to miss a full day of work, Lily from missing a full day of school, because we miss a lot of those. And that's where, really offering that care coordination piece within a medical home. But the Region 4 Genetics Collaborative has families that are involved on their advisory board, and they really work to come up with a family definition of, what is care coordination and what does it really mean to families.
The Region 4 Midwest Genetics Collaborative defines care coordination as a needs-driven, team-based process that values families as essential partners. Care coordination is intended to integrate care among multiple service providers, enhance the caregiving ability of the family, and maximize the potential of the child. Region 4 families talk about what this definition means to them.
It's helping us understand where our resources are, both in our local community and around our care center, and things that are offered at that institution.
We can't all do it ourselves. Care coordination, we're like, yeah, I'm the dad. Hey, I don't want anybody telling me how to run my kid's life or what meds he needs. But all of a sudden you're like, I can't even spell it. And so we need to ask for help,
Parents should definitely be considered equal partners in their children's care because they are the ones taking care of them on a daily basis.
Because it really takes relationships and making connections with people. We have a similarity. Now let's start to have some meaningful conversation.
We were invited into a care team, and our opinions were recognized in that process. When there were decisions to be made, they asked us to be a part of that decision making.
Parents are the ones who know their kids. We are with them all the time. When I call the doc and I say something's just not right, I know my kiddo, they need to listen.
She's kind of in the center of all those specialties and all these service providers. It's important for families to be really involved in the coordination of care because we receive all the information from these providers.
We need to know where to turn to because even if you may know of one place to go, they may not necessarily do all of that care that's needed. Nobody knows all the answers.
They need to provide them with the accurate terms and information so that the families can learn to be a partner in the care of their child.
I think it's important for families to be empowered to coordinate the care for their children because parents understand what it's like to live in the context of their own family situation.
We know that they're happy. We know that we've done the best that we can for them, and we've given them every opportunity to be productive in society. And I think that's really important.
In the beginning, I took a lot of direction from medical providers. In the middle of our journey, I started to learn more things. And today, I feel like I'm in the driver's seat for my daughter's care.
Okay, great. I'm actually glad that worked because, like I said, I just rambled on about care coordination and what that meant, but I think it's even more important when you're able to see families talk and really see them talk and share what it means to them. And one of the things is, families really want to be validated. We want to know that our opinions do matter and that we appreciate, all the time that you spend with us. I can't imagine in the day and age where technology and there's so much information, it must make providers crazy. I can only imagine because there's so much misinformation out there, but parents, they're always searching for answers. And so, the benefits of being in a medical home is, even like at Lily's provider's office, even though Dr. Turner's her main pediatrician, she has several partners, and of course, kids get sick a lot, and we see who we see when we get there, but pretty much they all have seen Lily at one time or another, and they all know us, and it really feels like, when we go there, Lily actually loves going to the doctor now, which you can ask Dr. Turner. It was a nightmare. We would be dragging her in and holding her down, about 10 of us, and she actually loves to go to the doctor now, which is crazy for me to think, but we do feel really supported there. That care coordinator within the medical home is able to, we actually got a binder, a medical home binder when we first started going there, and had a huge listing of community-based resources. And seeing as I was new to the Lansing area, that was really helpful for me because I had no clue about really anything at that point. But being able to partner with somebody and know that you're able to have that mutual dialogue, it really matters in making families feel more comfortable and more confident to be able to say, hey, I don't really know, and maybe things aren't going that well, where, without having that strong partnership that, maybe they wouldn't have felt that comfortable opening up and saying those things because, it can be really intimidating being a family member with, somebody who has this degree, who has all this knowledge, and sometimes, it's hard to even say that I have no clue what you just told me. Can you maybe bring it down in some terms that may be simpler terms for me, because I want to let you know that I understand you, but sometimes it's hard for families to say, I don't understand what you're telling me, but we don't want to feel stupid. And that's the importance of building that partnership, is where you can really get families to open up and feel comfortable to say when they don't really understand what you're explaining to them, and other things. So the role of the family members in this whole partnership is, like I mentioned previously, they are the constants in the life of their child. They're the expert in their child's individual strengths, the child's needs. I think most parents have a realistic outlook on what their children can and cannot do, what their needs may or may not be. And also, they are the visionaries who see that big picture and long-term goals. Whether, if it's your 5-year-old, you may not want to think about, what they're going to be doing at 18. It may be too hard to think that long-term, but, we like to see, be able to see that they're going to have, a place in life where they can be a productive member of society, where they can have friends, where they can thrive, where, they're accepted for who they are. And I think, that's really important when you're looking at a child and taking care of a child, providing therapy, et cetera, that you see that whole picture. Because, for instance, I had someone share with me that, her son, she wanted her son included in all the general ed classes, and it wasn't, she's like, he's not going to come out learning algebra. He's not, I know I don't need him in there to get math. He's not going to get that. That's not where his strength is. But I need him to learn the social skills. And I think those children in there, they need to learn how to live with him just as much as he needs to learn to live with other children who are his peers. And so I think that's, a really important thing to think about, and things for maybe you to think about when you are working with families. If you have a child that maybe is nonverbal, but the parent still wants them where they want them, the child's getting so much more out of it, and sometimes we just need to see outside of that box to what other things can they get from it? What other things are the people in, whether it's going into a mainstream class of another child. I think it's something that we all need to learn to really understand each other and live in society together as they become adults. And I'm not going to get into culture too much. Dr. White Perkins did an amazing job was it just last week? At our face-to-face 2 weeks ago. I've been to a lot of different cultural competency presentations, and I really enjoyed the way she presented it. But a couple of things to think of, and when we're talking about culture, really think about culture and how that impacts delivery of family-centered care, how that impacts when you're working with families. And so this definition we found, a culture is a body of learned beliefs, traditions, principles, and guides for behavior that are shared among members of a particular group. So, sometimes people think, oh, culture is, it's so big, but really it's not. We all have our own culture. Even if we were born and raised in the same town and lived on the same block right next to each other, we still have different culture within our own families, different traditions, different ways we may think about things, very different experiences, even though we live right next to each other. So when we're thinking about it in that way, and thinking about with the families that you work with, it's really like Denise said, last week or 2 weeks ago, really trying to open your mindset to what is the beliefs, what are those families' values, because the things that the family values are going to be the things that they really hold high, and also a great way for you to maybe get in to, get them to do whatever the therapy or some kind of, some way to work with their child even better and have better outcomes for their child. And so we do know, a family's culture affects, like I mentioned earlier, they may not feel comfortable asking the provider, can you re-explain to me what you said? I don't understand what you said. You may have a family that English is not their first language. Maybe they know very little English whatsoever, but that family may not feel comfortable asking you to re-explain it. So we need to think about these things and what can we do to assure that we meet families where their needs are, that maybe if we understand that English is not a first language, that we offer information in the language that is their native language. And can any of you share maybe some examples of families that you've worked with in a way that the family's culture impacts the way that either they ask for support, who they ask for support, type of support they need, or how the support is delivered?
Okay, so I've had experience working with a family with an Asian culture background. The parent spoke English pretty well, but there were still a lot of terms that I utilized as well as other providers that were very difficult. So Mom is very proud of her English, though, and is kind of intimidated with the fact of a translator, so that involved a lot of discussion and where that's appropriate and where it's really not needed. As well as a lot of cultural barriers just into maybe sleeping habits, where the best habit would be for the child to be sleeping on his own, but Mom culturally really wants everyone in the same room, in the same area. So those are just a couple of the things, but it's something we're always considering.
That's wonderful, a wonderful example. So can you share with us, how did you navigate that? How did you navigate the co-sleeping or the sleeping in the same room, and how did you guys go about navigating that so it worked out in the interest of, the family and the child?
So it really helped in our prioritization of what skills we worked on. So for this child in particular, he has a lot of barriers. So instead of working on sleeping right away, we focused on things like toothbrushing and hygiene. And then for sleeping, we just gave Mom some tips about when he does wake up and things that we can do. And we spoke with her like about future, if she feels as he gets older, if we can move to a different type of situation. And we're also in the process of trying to locate some local organizations that might be able to help us better understand their culture, because at this point we just feel like we might also not be as informed as we'd hope to be.
Wow, I really commend you and the organization that you work for, because that is really dedication to families that you are doing that. And if you have any issues finding any organizations, feel free to call me through the Family Center. If I do not know of them, I probably know somebody who does,
Okay.
and that we could do with if you're in need of those resources. But yeah, that is wonderful, and we have to work, like you said, we start at, maybe we don't touch the big stuff. We start out small, and while we're starting at small, we're working on building that trust between that family and the providers, right?
Yes, definitely, and thank you.
But you're working on building that trust because they are from a different, a different culture, different language, and they're trying to, like you said, you're trying not to make them feel bad if they're not understanding you, because it's nothing to feel bad about, because they've learned so much in English. But I think that's a really good example. Okay, we can move on. Just something really good for you guys to think about, and a really good example that was shared in thinking outside of the box and really trying to hone in on better ways to get support and buy-in from the family by understanding their culture better. So when we think about, cultural competency and, how does that relate to being family-centered? Well, I think we were just given an excellent example. I don't think I could come up with one better that we were just, that we're given, that Alyssa just gave. Right there, that is a perfect example. And it is, like Dr. White-Perkins stated, it is an ongoing process. We have to really be able to understand people who are maybe incredibly different, on opposite ends of the spectrum of ourselves. And it's just something that is a continual process of learning, building that awareness of looking inside and self-reflecting on any of the implicit bias that you may have that, like we talked about last week. We don't even know where this may have come from. Who knows? I mean, it's just the way that as we start from a young child and grow, and our brain builds with all these, all the information that we've been thrown at us. But it is an ongoing process to constantly gain more information, and I think you kind of go backwards and kind of go forwards, but it's something to really continue moving forward with. And I really appreciate that everyone in here is really open to moving along that continuum, and it's so incredible of you to be seeking out organizations that are going to help you understand a family's cultural and ways to help them instead of keeping them from being able to move forward as well. So the best practices, we know that, engaging in that cultural humility. So it's not just knowing the things that we know about the family, but respecting the things that they value, right? So we can know that maybe they all sleep in one room, and we can know that. So maybe we're not okay with it, and we may never do that, but there's still a difference between knowing and but then actually respecting that is that family's value, that's their culture, and being very respectful of that, because we don't want people to knock down any things that we may find completely normal. And I can't think of one thing off the top of my head right now, of course, but that may be completely normal within our culture and our values that other people may just shake their heads at. But so it really is about not just knowing, really respecting, letting families define the priorities. And I think that, the example that was given before, like you said, that's great. That was that family's culture. They all slept in one room. So they kind of, and you put that on the back burner and respected that family's culture on that. I think really being aware of any personal behavior that might be considered insensitive, and something, you know, I thought when I first came here at the Family Center, I thought I had a lot of great skills, and I thought I knew a lot of information about people from other races, and I really learned over these last 7 years that I really didn't know that much. And I know a lot more now than I did 7 years ago, but 7 years from now I hope to know even a lot more. So it isn't a passive skill, but an active one, you know, where we can self-reflect and look inside and really be open to other experiences. And I think when we can all become very open and honest and respectful at the same way, then we're going to be a much better world altogether. So moving on to a darker topic, talk about grief. And you know, when we talk about grief right now and working with families, we know that grief isn't just mourning the loss of a child, but in having a child with special health care needs or special needs or genetic condition, you know, families go through that grief of when they realize they first get that diagnosis. And depending on, you know, families that you'll be working with, you know, you've got kind of a big spectrum because you're going to be working with families who have children with autism spectrum disorder, other neurodevelopmental disabilities, so maybe disabilities that were not diagnosed at birth or prenatally. Whereas, you know, if you look at, you know, then developmental disabilities in children with Down syndrome, a lot of families are getting prenatal diagnosis nowadays. I had one, and that was 12 years ago. But nowadays, I think the new prenatal testing for Down syndrome, I believe you can find out a pretty accurate, 99%, I'm pretty sure it's fairly accurate at like 6 weeks right now. Excuse me. And so we have to understand the stages of grief for families. And just know that, you know, there are many stages. It is a normal, healthy reaction to a significant loss, while you know, we grieve for the child that we thought we were going to have. I know when I was pregnant, I did receive a prenatal diagnosis. I was excited. I found out I was having a little girl, and of course I'd had a son by then, and I was really excited. In my head, I had all these hopes and dreams, and you know, she was going to be a straight-A student, she was going to be a dancer, she was going to do all these great things, and you know, then I received that diagnosis, and I was crushed. I literally, I sat in my bed and cried for 3 days straight, or in front of the computer Googling. I did a lot of Googling as well. And, but, you know, that's a normal reaction to grieving for the child I thought I was going to have, and learning to, you know, accept and find hope for the child that I did have. So sometimes it's, you know, dealing in, you know, and you don't know where you may catch parents at in this grief process. And I think also, too, having a prenatal diagnosis or even an at-birth diagnosis of a child with a genetic condition is probably different than parents who have had a child who is developing typically, and then all of a sudden at some age starts regressing and losing skills. And I did not have that experience. I cannot imagine, but I have a very good friend, you know, a lot of very good friends who have had that experience. And you know, when we talk and we discuss like our grief or, you know, how we were impacted, and I'm like, oh, that's right, because your child was speaking, your child was walking, and then all of a sudden, and I'm like, I can't imagine that, because, you know, Lily was just born with 47 chromosomes, and she always was like that, so I didn't have to I don't even, I'm not really, I guess, any word to call that, but it was just a different type of grief. But I get, my whole point is that, you know, there isn't any right way to grieve. The grief is, like they show here, the tangled ball of emotions, and this is pretty much it. And you know, it could be that you're working with families and you may not have any clue that maybe it's an anniversary of something special, or an anniversary of a diagnosis. Maybe all of a sudden, you know, you have a parent in tears or lashing out at you and you have no idea what you did. Don't take it personally. It may have happened already. You may have dealt with families and all of a sudden maybe they've reacted in a way that didn't quite think was maybe appropriate for the time, but I always like to say don't take it personally. We don't know what may be going on inside, or, you know, like this tangled ball of emotions. You can be, I think, going fine and where you think you've accepted a lot, and then maybe you're sitting in the doctor's office getting a new diagnosis, and then all of a sudden it feels like that your whole world is crashing down again. I think I had a lot of sadness, not so much that Lily had Down syndrome, but I felt really sad for her that she would have to go through whatever she may have to go through. And I was really hurt. I felt not guilty so much that I caused it, but I hurt for her literally. Like, I loved her more than anything. It didn't so much matter to me, but I just really hurt for her, and I grieved, I guess, for the loss of her, but you know, she's always been Lily. She doesn't know that she hasn't, you know, missed out on anything. And you know, I think ultimately, as parents would feel that, you know, it's been one of the greatest things that's happened in their life. I would hope, besides all the medical things, but and just know that grief isn't always linear, and two parents can be at different stages. You know, when you have a married couple or partners, or however that partnership may look, we have to realize people grieve differently. Men and women grieve differently. You know, I've had friends who they seem to get on the ball on acceptance pretty early on, and husbands went on for a couple of years still really struggling. But we have to remember there's no wrong or right way to grieve, and that it can reoccur at any time. There could be triggers, birthdays, date of diagnosis, the beginning of a school year, school challenges, anytime a child is reevaluated, anniversaries, and watching other children of the same age do things your child can't do. I know for me personally, just a couple of years ago, they have a little fair in DeWitt every year, and all of a sudden I noticed my daughter's friends were there, and they were in groups of 3 or 4 without parents. Now, I'm sure their parents were there somewhere, but it made me really sad because Lily was there with me, and she couldn't experience what that was going to be like. I couldn't have just let her say, okay, I'll see you later, because, well, who only knows where she'd end up at. Probably ordering pizza at Hungry Howie's, but I don't know. You know, it's not something that she didn't have that level of independence to do that, and that triggered grief for me. So just remember that, you know, everyone experiences stages of grief differently due to, you know, people want to talk about it, don't want to talk about it, depending on the diagnosis. But I think it all comes down to that everyone wants to have their feelings validated. We all want someone else to say, you know, it's okay that you feel that way. You know, you feel that way as long as you need to. I have quite a few friends who've lost children, and sometimes the things that are said to them, not necessarily by professionals, but by other people, are just kind of horrifying to me. So, you know, but I think just validating feelings and listening and being there, you know, lives aren't comparable. Just because someone has one child doesn't mean that the loss of their other child is okay because they have another one. You know, I said a lot of different things that families hear, and it's just, you know, it doesn't help them at all. It doesn't help them except maybe making them angrier. But you know, just remember, it's a process that we all must work through individually at our own pace. And unless you really feel that a family you're working with is just maybe really getting undergoing more like a clinical depression, then note that, you know, this is a process that will probably be with them throughout their child's lifetime and, you know, through adulthood, especially with the developmental disabilities. There's so much to think about long term. They can't just, you know, all right, you're done with high school, you're going to college, see you later on your own. There's a lifetime of planning, a lifetime of making arrangements for when you're no longer around to care for them, and just a lot of things that are really difficult to think about sometimes. And so how can you support the needs of the families that you serve? I think one of the biggest things that we've spoken a lot are families need resources. They don't know where to turn to. You know, they've maybe been given a diagnosis and they don't know what's out there. They don't know what is out there that maybe can help their family. So So you say, current resources, make sure they've been vetted, make sure they've either somehow been vetted, called, or other families have used these resources, and any community-based resources that families can go to. I know generally, especially in the beginning of getting a new diagnosis or your child being diagnosed, parents want to be connected to other parents. They want to connect with other people who have a child with autism, who have a child with Down syndrome, who have a child with Rett syndrome. They want to know, what is it like? I want to connect with somebody because when you're first thrust into that world, you feel like you are in a world that nobody else has a clue about. You feel like you're almost just, just like you feel like nobody could possibly understand what you're going through. And I know for me, I early on found an online support group for families all over the country and actually outside of the U.S. who had children with Down syndrome. And I'm still friends with these people. I've met a lot of them in person, and like I said, they're all over the United States, some in Canada. We have one in Israel as well. And we are still very tightly connected over 12 years later. And I don't think I could have made it through those first year or two without the support of other families. And I think just for me, when I met these families, it was, I couldn't believe the amount of, outpouring and encouragement for me, support for me, and telling me, everything's going to be okay. Once you have that baby in your arms, you're going to, still the same baby you always had. You just have a diagnosis now. And, I had people send me cards. I had people send me books. It was the first time, I think, in my whole entire life that I ever met a group of people that just poured their hearts out to me and really just opened their arms and accepted me. And it was one place I always knew I could go, that no matter what I said, they got it. Even though I had, very close with my sister and my son and my niece, who were all very great support for me during my pregnancy, it didn't matter. I mean, even still today, I can't share things with them, but they won't get it like somebody who lives a day-to-day life. So there are many organizations that can help with peer-to-peer support. Family Center, where we work, we connect families with other parents who have been trained, but there are also a lot of people like online support groups. Excuse me. And but there's a slew of all kinds of support, and I think one of the biggest things that families need right away is support from other families. They need accurate disease-specific resources. They want honest information. They want you to, share with them what can they expect as to whatever, at least to the best of your knowledge, and then any other evidence-based programs. But also remember, they may need to be connected to community mental health within their area. But whether they're connected through a care coordinator in their medical home or somebody through their health insurance, but finding a way for these families to get to the resources that they need, or get to somebody who can ask those pointed questions. Because many times, especially in the beginning, families don't know what they need. I mean, we hear that a lot to our family phone line here where I work, and they'll come get me and they'll be like, I don't know that she knows what she needs, but I can tell they need something. So, and I'll take the call, and we just kind of ask some great, pointed questions, see where they're at, and really help navigate them and point them to things that can really help support them. And a lot of times, especially now, fathers are more involved than ever, and there are a lot of great programs out there for dads as well. And so it's not just the mom that wants the support any longer. These are some of the things in the years that I've done different trainings that we have kind of come up with, what families want providers to know. Trust my instinct. Parents usually have that really good maternal, that mother instinct, and we just usually generally pretty much right on. So really trust that instinct of the parent is coming in and saying, something's just not right. I can tell you something's not right. Listen. Remember, the child is a child first. Try to use proper and respectful terminology. Remember that each parent processes evaluation information differently. For instance, I'm always one, I like to know everything. So anytime I get an evaluation, anytime, especially in the beginning when they did the evaluations to tell me where my daughter was at developmentally, I wanted that, and I loved looking at them. I have plenty of friends that will take that, they will not look at it, and they will file it away. And so don't get offended if that happens. That's nothing personal to you. I have a lot of friends who do not want to look at that because they don't really think that that really is, you know, because not because that's not maybe where their child is developmentally, but just they don't really think that that expresses their child as a whole child as they see them. And some parents can't look at that for the reasons of it's too hard for them to say, oh, my child's 5, but maybe developmentally they're 1. It can be difficult. It can be difficult when maybe their oldest child is a child with developmental disability, and now they have another child that all of a sudden is barreling right over any milestones their first child's already had. And so, you know, you have to think of even that grief aspect in other siblings that they may have. When they have a child that's younger, but now is able to do more than their child with a disability, that can be really hard on parents having to watch that. Also, we discussed a little bit about people in person first language. Please try to always use people in person first language. We do know, and especially it does seem to be in the world of autism, where a lot of self-advocates who have autism they want to be called an autism, I mean Aspies. They're calling themselves Aspies in this other language, and so that is very different from the Down syndrome world, where we really want, say, a child with Down syndrome. So, you know, we can't always know what to say. We can't always, you know, get everything right, and I think parents are forgiving, and you know, a lot of parents put a lot of emphasis on that, but there are also a lot of parents that will at least, you know, try to educate other people. So as to the best of your ability, try to be conscientious of using person first language. Sometimes office personnel can be a barrier, so sometimes it's easier for us to call and make referral appointments as opposed to maybe a care coordinator making that appointment and then calling us with a date and a time, and we're like, oh, I have a meeting at work, I can't make it that day. And so sometimes it might be better that the families do make those appointments, and that way they can at least, you know, schedule a time that they know will be a good time for them, and not waste, you know, the office staff time, their time, and everyone's time. But families really appreciate the time that you spend with them, explaining complicated issues, listening to them, hearing their concerns, validating, you know, their concerns and the worries that they may have. Also validating that you do see the good things they see in their child, and validating their strengths, because, you know, we try to go from the strength-based, and we can really validate that will really empower the family to, you know, really appreciate that, and then see themselves, oh, I can be an equal member of this team. You know, we can be partners, and we can discuss these hard questions and these hard choices that we may have to make, but we can discuss them, and we can negotiate, and we can, you know, really compromise if we have to, but still they feel that they're being heard and they're being looked at from the strengths that they do have. And then ultimately, you know, families want to know that we really need your help. I'm so thankful for all of the incredible medical, educational people that are in my daughter's life. You know, we have, you know, not just medical, we have a whole slew of educational people between her special education teacher, occupational therapy, physical therapy still. We have hearing impaired specialists that come in. I mean, a huge amount of relationships that we have to navigate, and I appreciate everyone and all of their input that they give to us, and I think most families feel that way as well. And this is actually my daughter Lily. She's much taller now. This is probably 5-6 years ago, but you know, each person is unique. Like this little poster says, just moved. You know, we all have our own strengths, abilities, and Okay. Our strengths, abilities, and I can't read it now, but you get my drift. Oh, you can go back. Oh, there we go. We all have, like everyone, people with Down syndrome achieve many strengths, talents, and successes. So just like no two people are the same, there's no two children with Down syndrome that are the same, just like there's no two children with autism or any other. We all have our own unique strengths, and I think families appreciate it most when people see that. I know in the Down syndrome world we hear a lot, oh, that child is, they're so happy. Oh, they're so loving and happy. And I'm like, I don't know who they're talking about because that's not the child I got. I got sassy, and who do you think you're talking to? But not, you know, I want to love everyone in the world. That wasn't my child. And this is actually my son, Dustin and Lily. And these were some of, we were holding a sibling conference last year, and I was trying to get my son to come and be on the sibling panel, which he said, oh, absolutely not. That's what you do. I do not do that. And but anyway, so these are a few of the thoughts that he gave me about his sister Lily. And I remember when I first told him after getting my prenatal diagnosis, he was like, oh, okay, that's no big deal. We have kids at school that have Down syndrome. And I was in tears and this big, you know, mushy mess. And like, oh, no, it's no big deal at all, Mom. And because she was very, very sick when she was born, which we knew, but he was there at the hospital, and we ended up having emergency C-section while I was being induced. It was supposed to be a regular vaginal delivery, and then we ended up having to have an emergency C-section. And so he actually saw her before I did, and she had tubes, and she was on a vent, and she had needles and tubes everywhere. And as he said, it was really hard to see her in the NICU. He was really, really scared. 6 months later, Lily had open heart surgery, and I could not, and he was driving at the time, so he was 17 actually when she was born. And I was really upset and devastated because he would not come down to the hospital to see her. And once we talked about and had this conversation last year, he told me it was so hard for him, and that was why he did not come to the hospital after her heart surgery. And here I'm thinking, oh, he's just a 17-year-old, you know, being all about, you know, self-centered, and it's all about me right now. But little did I know that it really, really, really kind of stuck in his mind. And he said he was really worried. She was, before her heart surgery, she had went into congestive heart failure, and yeah, she would just be sitting in her crib, sweating, like doing nothing at all, and she would just be sweating. And he, like he said, oh, she's smarter than I ever imagined she would be. He knows. That girl is. She's real good at manipulating as well. Just yesterday, I was getting reports from school so I can stay on top of what she's doing in school, and in the note it said, Mr. Thalen gave everyone social studies packets. Lily took hers and put it in the recycle bin and told him, I don't want it. I'm like, oh, lovely. And like, that's my daughter. Yep, I don't need it. I mean, great. Anyway, it was kind of a priceless moment last night when we discussed this, and I pulled a copy of it out of my work bag, and she wasn't real thrilled, needless to say. But he loves her, and Lily loves Dustin. He lives in Wayne County. We're in Lansing. We don't get to see him often enough, but they adore each other. And I think the bond of siblings is great, you know, no matter what, but it's a really wonderful relationship. So mainly, you know, family-centered care is really professionals respecting what the family brings to the table, families respecting that education and expertise that all of you bring, and really building that mutual respect between all people can really help make the outcomes, you know, go really well. That's what we're trying to do, is have great health outcomes. So just a few things to remember is words can create barriers. Use person-first language. Learn as much as you can about if there's a child and you know you're going to be seeing them, and it's something you don't know very much about. You know, if you have the time to get some current information, I think that's always good. Avoid using stereotypes, outdated myths. Like I said, oh, those kids with Down syndrome are all so happy and loving. Don't prejudge. Don't just think. One where one of the examples in my mind is I had a physical therapist at school at her IEP tell me, well, they would no longer be working on skipping and hopping on one foot because Lily had not met it and it says, by her evidence-based research, said that if a child does not meet this by the age of 6, they will never do this. And Lily was 8 at the time. And I asked her, I'm like, well, I would like to see this research. I said, because I'm like, is that research on typical children, on children with Down syndrome? And she said, no, actually, it's research for, you know, all children. And I think she said they give the children with Down syndrome up to the age of 5, where a typical child was 5, or vice versa. And I just told her, I said, well, I'm concerned that you tell other families this, and I would like for you to maybe think outside of what that data tells you, because I have to believe in all the research I've done on Down syndrome is that people with Down syndrome continue to learn. And so maybe she's not getting it now, but I have to believe that if we work on skipping or hopping on one foot, maybe not hopping on one foot, but we've got really low tone and she's overweight. So I said, but I have to believe if I worked on this with her every single day, one time within the next 10 years, she's going to get that. And so I just want all of you to know, this was like 4 years ago, well, Lily just showed me the other day in the apartment that we live in, she can hop on one foot. And I'm going to take a videotape and I'm going to send it back to this physical therapist. But those are the things I'm telling. Don't preach. I believe that things are possible. You know, she might go tell other families that maybe they'll give up. And it's not so important to me that Lily skips or hops on one foot, but I just want people to be open to saying, well, we're just not going to do that anymore, because if they didn't get it now, they're never going to get it. Don't place limits. That kind of goes along with the example I just gave. You know, validate parents, family concerns. It's okay to say, I don't know. I think, you know, you see a lot of children, children who maybe have a lot of conditions that not many people know enough about. And parents and families respect that when you say, I don't know. And it's okay that you don't know. We don't expect all providers to have all the answers, to know everything. And then most importantly, just believe anything is possible. And so here's my contact information. If there's, oh, you know what, I apologize. I think I missed an L in my email. It's huckleberryl@michigan.gov. And that's my direct line. So now I can open it up for questions. If anybody has any questions or comments. Sure.
Just going back to, you were talking about support groups for parents. And I recall some years ago, we had started a support group. Well, not so much a support group, but more a group for dads for part of the Detroit 360 project that the Michigan DDI had several years ago. And I was wondering if you could comment a little more on that as well, because you mentioned that the groups for dads are growing out there, and I noticed that, and this was probably about 7 or 8 years ago, and we did have quite a few fathers that were interested in these resources but didn't know how to connect to them.
Right. Now, is that still going on now, or did that end up fizzling out, Mike?
No, I think that the funding for that project ended some years ago, but I'm just remembering how popular that fathers group did become through the course of that project.
Oh yes, absolutely. Now, so for instance, where I live, we don't. There are quite a few Down syndrome associations in the state of Michigan. Here in Lansing, we don't have one of the bigger ones, but they're working on a lot of things. But one of the things they do, so sometimes it may be through like Down Syndrome Association or another association specific, disease specific. You know, they have dads nights out. They get dads to meet up. Scott Newport, who is a friend as well as someone I've worked with, and some of you may know as well. He was on the care coordination video we talked about, but he is on the Patient and Family Centered Advisory Committee through U of M, and he does training at U of M for providers, and also he supports dads throughout the state of Michigan who have a child that is terminal or who has lost a child, because he is son Evan unfortunately passed away. So I know he has a lot of connections. I believe they also, I believe it's in Livingston County, had a dad's conference once a year.
That's very cool.
And so, but one of the things that we do here at the Family Center where I work, we help people connect to resources, whatever that may be. So if anybody is in need of where are these support groups at, are they in my county, they're not in my community, what can we do to get them started? I can certainly help here, and I can certainly help get that information for you. But one of the things that we also can do through the Family Center is connect parents to other peer mentors. So we do have dads that attend our parent mentor training. So we do have dads who've been trained as a parent mentor. So if there are dads out there that would like to connect with another dad, they can contact our Family Center, and through a brief intake on the phone, we can connect them with another dad. Now we do that with moms as well, siblings. If we try and help with finding sibling support groups or sib shops within the local community. Great. Well, thank you, everyone, and I very much appreciate having your time tonight, and look forward to speaking with you all again.